So, good evening, everybody. This is Irfan Abbas, and welcome to my webinar on implants in the aesthetic zone. Thank you very much to the OIO for the opportunity to lecture for you on implants in the aesthetic zone. My name is Irfan Abbas. I'm a prosthodontist and implant surgeon from the Netherlands with a private referral practice, and I'm also an editor, etc. So today we'll be talking about implants, and we'll look at many pictures. And normally I would always start with the camera I use. It's a Nikon D90 with a macro 62mm lens and a Nikon and the Sigma ring flashes. As I already showed, I have my private practice in Bussum in the Netherlands. It's quite near Amsterdam, where I especially work on referral for other doctors. So I always say I have four jobs. One, of course, is my private practice where I work with my colleagues on oral implantology and surgery and placing the implants. My second job is doing lectures all around, and of course during COVID it stopped. But luckily, from this now moment on, we will start with again the events on lecturing for full audiences. So that's always a good idea. And my third job is making publications. So I have now more than 18 clinical publications on especially doing what kind of technique you should use for which treatment. So this is always very fun to make these kind of clinical cases. And of course, my main job besides my private practice is I have my own Abbas Implant Academy where we teach doctors a full course in oral surgery and oral implantology, which is an 8 full-day course in the Netherlands with adjunctive a live surgery course in Tijuana, Mexico, where we place in 4 days around 20 implants with sinus for elevation, immediate implants, guided bone regeneration, etc. So this is a quick introduction about me for what I'm doing in normal life. So this evening we will talk about implants, and of course always the question is why we should place implants. And although I'm not here to talk long about the question if we should replace teeth with implants, we should always keep in mind what's the indication of implants. And I think one of the most important thing is that implants are only to replace missing teeth or failing teeth, but not just teeth. Now, if you can salvage a tooth, it's always the best idea. If you can salvage a molar or premolar, I think that's always the best way to go, and try to extend your implant placement as long as possible. Just delay it, and just when it's absolutely necessary to place an implant, then it's a good idea to place implants. So today we'll have a small discussion on placing implants in the aesthetic zone. And people always think that our job with implant placement is this one. So people always think that's the most sexy part of oral implantology, making the incision, cutting it, drilling inside of the bone, making your osteotomy, placing your implants. But oral implantology is much more about that. First of all, doing which treatment and what time is always dependent on your implant system. So you need the correct screw for the correct indication to do certain kind of treatments. And it's my belief that we can only use around 10% of the available implant brands to do immediate implant placement, while other brands are not suitable for immediate implant placement. So first of all, you must know everything about the design of your implant. Secondly, it's always about the planning. You need correctly to plan your aesthetic case first, and then we can go to the location of your implant, the timing, and if you have all those things correctly, then the surgical part is very easy and doable. And after the surgery, of course, we are not there. We're not just dentists who are placing screws inside of mouths. We are rehabilitating a single tooth with together also the soft tissue. So the temporary prosthetics and the final prosthetics are a big part of the success of what we get from our implant. So if you keep all these things in mind, we can talk today about implants in the aesthetic zone. And I think the timing of implantology is very important. So at which moment in time we should place our implant. And we can place our implant immediately after removing a tooth, immediate delayed, or placing it in a healed ridge. And I think more and more we're going to the situation that we can place our implants immediately, just after extraction. And with that technique, we can salvage most of the soft tissue, and we can try to keep everything in the same situation instead of removing tooth and letting the whole soft tissue and bone biology collapse. So we have immediate delayed, and the healed ridge. And of course, we have one more time point, and that's the socket preservation. In certain cases, we need to just preserve the socket and place our implant at a later time point. And that can be when it's not able to place the implant for these kind of situations. So we have immediate delayed, and of course the healed ridge, and we can do a socket preservation and do delayed implant placement. But the question is always, if we have a case in aesthetic zone, when we should do what and how we should do it. And to understand that, we need to go one step back, and we need to understand why is extraction so important and what happens. And of course, everybody can tell you, well, if we remove a tooth, the resorption process starts. So when we remove the tooth, the soft tissue will collapse, the bone will collapse, and we need to rebuild it. So let's take a look what actually happens. And Professor Araujo and Professor Linde published a lot on these cases. And I think these pictures, what you see now here, are pictures that everybody really knows from their heart. And what they basically showed was when you remove a tooth in 8 weeks' time, you get a massive resorption of the hard and soft tissue, which can lead up to 40% in the most coronal area. And at that time, at the early 2000, everybody thought, if we place implants, will it prevent the resorption and the remodeling of the hard and soft tissue? And we thought by placing just an implant that would be true, but these researchers very nicely show that if you remove a tooth and place an implant, the remodeling process will still continue. And you can lead up to bone resorption after placing immediate implants. So that would not be the best idea. A second research they did is to see what would happen with the ridge if they placed a biomaterial, in this case a xenograft material, to see what happened with the ridge. And there they found that in the 6-month grafted sites compared to the 6-month control sites where they basically did nothing, the graft site was significantly less resorbed with the hard and soft tissue. And if you look at these numbers to the left, so the left part of the table is of course the control group, so you get around 35% soft tissue alteration and hard tissue alteration in the most coronal part, where we compared with the grafted side, it only declines around 12% with a standard deviation of around 10. So please remember those numbers. So that means that even though if you remove a tooth and do a bone grafting procedure, we will always lose around 12% of the thickness and the height of the soft tissue in the most coronal part. And this is very important because the most coronal part is the part that would be very clearly visible for when the patient smiles. So according to this research, we know if you remove a tooth and place an implant, we still get a resorption. If you remove a tooth and place a bone graft, we can counteract the resorption, so the resorption will still continue, but it will be less, around 12%. So the next idea was the combination, of course, with a dental implant and the guided bone regeneration. So in immediate cases, remove a tooth, place an implant, and place the bone. And of course, these were remarkable results because by removing a tooth, placing an implant, and doing a simultaneous bone graft, they could also prove that there was much more bone still intact with a xenograft bone instead of autogenous bone in these cases. So just by looking at these literature cases on beagle dogs, we can conclude that remodeling of the extraction socket is severe in the most coronal part, which can be up to 35% if we just remove a tooth. If we place together an implant, that will not prevent the remodeling process of the hard and soft tissue. But if we place a deproteinized xenograft, that will reduce the remodeling, but you still get the remodeling of the hard and soft tissue up to 12% in the most coronal part. And xenograft and implant reduces remodeling, and autogenous bone doesn't seem to do the best remodeling because that can also resorb, of course. So by conclusion of these studies, we can ask the question again. So if we have a front tooth which is failing, which has to be removed, if we don't do anything, we get around 43%. This is a human study of Jung in 2013, where they compared patients who were in need for extraction. They compared CBCT images prior extraction, 6 months after extraction. And once they put in something inside of the socket, there was still resorption in the most coronal part, but up to 17%. So there was a significant difference by doing a bone graft immediately. And looking at the studies of Araújo and Linde, you can also conclude that if you place an implant doing a bone graft, you will get the same result. But still, minus 20% is still some resorption. So then it comes basically to the question, can we take the risk of getting a resorption of the soft tissue after an extraction in the aesthetic zone? So of course, everybody would choose the right side, but if we have the left side in our situation, we can rebuild it, of course, with some surgeries. And then first of all, you open up, place your bone graft. Secondly, you place your implant. Thirdly, you do a second stage surgery. That's already 3 surgeries, which could be avoidable in certain cases. So if we can avoid these kind of surgeries for our patient, that would be the best thing. So if we have a failing tooth in the aesthetic zone, the most important thing to do, and I don't believe in doctors who do not make a CBCT, is the most important to make a CBCT because we need cross-sectional images. We need cross-sectional images. And in my webinar next week, we will go in many details on looking at how to make a CBCT and how to read the CBCT and how to read the images, how to get to the cross-sectional images from the multiplanar reconstruction, from the curved plane reconstruction. So we'll do that all in 1 week time. But today we will just understand how the 3D of a tooth will work. So always make a CBCT before extraction, because once you're looking at a cross-sectional image, then you can really see what kind of extraction sockets you have. And of course, Joseph Kahn did some research. He made all kinds of type of sockets. And I don't think that's the most important thing, because if you make a CBCT, you can plan your implant virtually. You can see where we will end up by placing an implant. You can see where we will end up according to the nasopalatal nerve and nasopalatal foramen. So it's very important to make a 3D planning in multiple dimensions. And of course, we can measure the width, because normally we need around 8 millimeters of width, because if we have an 8 millimeters of width in the buccopalatal direction, that means if we place a 4 millimeter implant, which is basically the most used diameter in oral implantology, that means that we have around 1.5 to 2 millimeters on both sides, palatal and buccal. So if we have those 80%, we can place an implant immediately. If we, 20% of the cases, if we don't have the 8 millimeter, we need to extract and do a early implant placement and augment everything. And if we have more than 80% of the more than 8 millimeters, we can extract and place an implant immediately. So it's rather to preserve than to reconstruct. But of course, there are cases where we have the width, but we will not achieve our primary stability by placing our implant. And then it's better to do a socket seal and go for a delayed approach. So that's the first part of my lecture, is knowing what will happen if you remove a tooth, and that will always give around some resorption of the hard and soft tissue. If we do nothing, it will be around 35%. You need to rebuild everything. If we do something immediately, we can lose around 20%, and we can counteract this with, for example, a soft tissue graft. So now, implants in the aesthetic zone. It's very important to understand what do you expect as a doctor from your treatment, and what will your patients expect. So let us look at this first male patient who needed an implant. And I think if I ask you now, just look at this picture and tell me which tooth is an implant. Just take a few seconds and look at which tooth do you think there's an implant. If you said a 2-1, that would be very reasonable. Of course, we're always looking not only at the tooth, but also at the soft tissue, because we know if you remove the tooth, we get soft tissue collapse and we get some collapse of the papillae. And of course, you're absolutely right, there's a papilla retraction of the 2-1, but actually in this case, the 1-1 is the missing tooth. The 1-1 is the missing tooth, but even though by doing everything correctly and by using what we know from our biology, we can reconstruct a implant tooth which looks better than a natural tooth with a which already had a cervical recession and a recession of the distal papillae. So this is a quite nice Best and West score, or white or pink aesthetic score. This is quite well. But I always try to let people understand we need a comparison, because as we saw before, if we're doing immediate implant placement together with a bone graft, according to the literature, we will lose around 20% of the soft tissue. So now if we look at the same patient before extraction of the 1-1, in one word, what do you see as a difference from the previous picture? You're absolutely right. The soft tissue is much, much thicker than the before situation. So what basically happened here is, once I remove the 1-1 and I can place my implant perfectly, I can get a perfect Best and West score, but still by doing the extraction, the soft tissues collapsed around the 20% as we saw. The papillae retracted a little bit, distally papillae retracted a little bit, so we still get the retraction. But the thing is, it was not visible for you guys because I just showed the right picture. And that's very important to understand as a doctor and as also as a patient, that if we need to remove a tooth, it will never be as perfect as it was. And I always tell my patient, I will try to reconstruct as close to nature as achievable or as visible. Because if it's visible for you. If people smile and other people don't see anything out of the ordinary, out of something unusual, you will have done your job. But it's very difficult to get everything correct. So what are the most important things on placing implants in the aesthetic zone? I always say there's 5-dimensional implant placement. We have the mesial distal. The implant should be correct in the middle of the tooth. Of course, preferably screw retained. Facial oral. You need to place your implants much more to the oral side than to the facial side. The correct depth in relation to the anatomical structures. We know from the studies of Professor Linkevicius that we need to look at the soft tissue thickness, and we need to place our implant around a 4 millimeters of vertical height of soft tissue. And we need to look at the bone density. So this could be, of course, for all kinds of implant placement. But what's also very important is the numbers on aesthetic implant placement. So we know that we need around at minimal 1.5 millimeter bone around the implant, which will keep your soft tissue at the correct area. We need a depth of 3, preferably even 4 millimeter depth from the gingival height. That means from the zenith point to the neck of the implant. And of course, this should be a bone level implant. Do not use a soft tissue or tissue level implant in the aesthetic zone, because that would be just wrong. So we need the correct depth, and then we need to take care with our temporary crowns and our definitive crowns of the cervical and emergence profile, which we can always need a transitional crown in the aesthetic zone. And then we can go from the left to the right side, of course. So if we have this kind of patient, we can open up the soft tissue, and this is then eventually achievable for our patient. And the last part is, of course, the papillae. The papillae is very difficult, and we know this from a study many years ago of Professor Dennis Tarnow, of course, that we need the bone to the contact should be around implants around 3 to 4 millimeters. If you have more, it's very difficult to get the papillas, of course. But if we look at the same case again, you can see that my implant depth is quite deep, but the papilla are much more higher than where it is. And in this certain case, what keeps this soft tissue around here? That's not my implant. That is not my implant. That is the most crestal bone of the adjacent tooth. So the neighboring tooth of my implant decides where my soft tissue height will be. And I think that's very important to understand, that if you're placing 2 implants next to each other, the bone peak will resorb, of course, and the soft tissue and papilla will retract as well. So what's very important to understand is papillas are made by the bone peak of the adjacent natural tooth. So always try to save a tooth which is neighboring tooth, so we have implant tooth, implant tooth. And the downside is, if we're placing 2 implants next to each other, then we get around situation like this, of course, where 2 implants are too near and too far to the labial side. And this is, of course, a complete aesthetic failure. On the right side, it goes already better. I have here implant 1, 1 and 2, 1. And by doing things immediately and also immediately placing temporary crowns, I managed to keep some of the soft tissue intact. Or in this case, we will place 2 implants next to each other. You can see that the central papilla is, of course, resorbed. But by using a high contact line, we can achieve some kind of visibility of a papilla. It's a pseudo papilla, but if this patient smiles, you will not see something very strange. And the last part is, of course, if we use a dummy. Clearly, you can see that on this part here, the 1, 1 is a implant restoration, and the 2, 1 is just a soft tissue. This is a dummy bed, and by using a 2-unit bridge on 1 implant, we can achieve this as well. So with that, my advice: if you have two centrals, place two implants. If you have a central and a lateral tooth, central incisor and the lateral incisor missing, try to do a cantilever bridge on one implant. So that's the soft tissue. So again, let's recapitulate. We know now that if you remove a tooth, you get some kind of resorption. If you do an implant immediately, we can try to preserve the soft tissue in the bone. If we're doing implants later on, we need to rebuild everything. We need to place one implant, and we need the bone peaks of our neighboring tooth to keep the papillas intact. And if you're missing two central incisors, we can place two implants. If you're missing a lateral and a central incisor, it's better to place one implant and make a 2-unit bridge. So what are the most mistakes in implant surgery? We have the planning failures, the surgical failures, and of course, just placing the implant in the wrong patient, the patient failures. Looking at these three cases, what are the most mistakes made in implant surgery, you think? I will give you 1 minute to answer. I will give you 10 seconds to answer this question. And again, you're a very smart audience, of course. The most mistakes are planning failures, placing the implant in the wrong location. So it's very important to know if you place an implant, mesiodistal, buccal-oral, depth in relation to anatomical structures, relation to the adjacent teeth, and the bone density. So if we look at this case, we see it's clearly a failure. And I try not to show failures by other doctors because, let's be honest, I have enough failures myself, because just by failing, I really thought, looking at cases, how can I prevent this kind of failures for my patients in the future? So this was a patient. The medical stage was she has some heart valve irregularities, heart palpitations. She's a non-smoker. And before medication, pre-medication, I was prescribed 2 grams of amoxicillin 1 hour prior to surgery, ibuprofen 600 milligrams as a painkiller, and the patient always use a Blue M oxygen mouthwash. I always look at the clinical status as well. I don't treat patients who have periodontal disease. So if they had periodontal disease, if they have now a healthy periodontium which has been treated, I will treat them. They need oral hygiene, proper oral hygiene, and of course no carious lesions. And of course there must be enough interocclusal space for placing the implant and placing your restoration. So this very kind lady, she was missing the 2-3 area just around here, and she had a bonded bridge, and she asked me, can you replace it with an implant, because the bond bridge came loose already a few times in the past year. So I removed the bridge and I felt the patient, and the buccal was very thick and the palatal was also good. So I said, okay, well, this is doable. This is doable. Let me give you some anesthesia and we'll make an incision. So I made a vertical releasing incision with a mid-crestal incision around here, and we opened up the flap. The soft tissue thickness was perfect. That was around 3 or 4 millimeters, so I can just place my implant at bone level. The thickness was around 6 millimeters wide. Well, that's an easy case, right? Just place the implants. It's very difficult to miss. So we just drilled up inside of the bone. I got the small dehiscence at the buccal part. I said, no worries, I will fix that with a bone graft. I tried to get a palatal direction so I could do a screw retained crown afterwards. And I had correct soft tissue management, which I really moved the soft tissue so I could close after the bone graft. And then I placed a AnyRich 4 by 11.5 AnyRich bone level implant. Here it goes in. It's a very nice blue implant because of the calcium ions which are on top of the implant. And here the implant's almost fully in, and I placed the implant 1 millimeter subcrestal of the bone. So of course, buccal, there was some opening of the bone. I told the patient, no worries, let me place the cover screw and give a put some bone augmentation. So we used a collagenated xenograft, in this case from the company of Osteobiol from Italy. So this is the MP3, which is cortical cancellous chips with 20% of collagen, is already wetted, and over On top, I place two membranes covering it up and suture everything. First by tacking sutures which will stabilize the membranes, and on top the soft tissue. Closement. And the patient got a partial denture. So in 2 weeks' time, everything was okay. We removed the sutures. The soft tissue looks very well. There's no pus coming out. So the whole soft tissue healing was perfect. And then the patient came back in 3 months, and you can see the difference. The soft tissue has collapsed quite a lot. Once we did our second stage surgery, you can see where we lost a lot of bone on the buccal side. So, getting back in hindsight, what went wrong in this case? What should we have done differently? Well, I think that's quite easy because we did not do a planning. We did not do a planning. We just opened up, made an osteotomy and placed an implant. So now let's do planning in hindsight then. What's the occlusal line? Your implants should always be around the occlusal line or even more to the palatal of the occlusal line. But this implant is clearly moved to the buccal of the occlusal line. Now let me virtually plan a canine. This is the position of the canine, and as you can see, my implant is in a fully wrong position because on the left picture, that is where my implant should be. And now with the correct planning, we can understand what happened. Most probably the tooth 3 failed due to a vertical root fracture on the palatal side. So we're lacking a lot of bone on the palatal side, where the bone augmentation should have been instead of the buccal part. And by augmenting outside the bony envelope on the buccal part, this will not heal into the bone because the body will not let us. So we had a discussion with the patient. I told her, well, it's a big failure. I'm sorry. This is not what I had in mind. We needed to plan better. And she just asked me, how can we solve this case without removing the implant? So I told her, let me do a palatal incision, a roll flap instead of a normal H incision. So we made a roll flap from the palatal side to the buccal side by thickening the soft tissue, And after which, now you don't see the implant shining through anymore. And then we made a temporary restoration to open up the soft tissue. And then our dental technician made a screw retained abutment, individualized abutment with zirconia on top, and over which we placed we cemented a crown on the zirconia part, and as you can see, the soft tissue healed quite nicely, and now already a few years in the mouth, everything is going quite well in this patient. But of course, this is a aesthetic failure, and I was saved by the patient because when she smiles, she doesn't show. So now let's see what happened here. The problem is as follows. Of course, we all know that in our central incisors, upper and lower, our teeth are moved very much to the labial part. So we have a very thin buccal bone plate, and still with 1 millimeter thickness of soft tissue, we got around 1.5 millimeters of height. Now let's compare this with implants. We know there are many differences between a tooth and implants. It's the amount of vascularization, the amount of fibers, vertical fibers, and moving and circular fibers. So we have far less fibers around the soft tissue of our implant. And according to this, that means that if we have this much soft tissue, the vertical height of the soft tissue is less than with a central normal tooth. So it's the complete other way around. For 1.1 millimeter vertical soft tissue, we need around a thickness of 1.5 millimeters. And if we now go back to our own teeth, that means that if we remove a tooth here at the left side, and this is the most highest soft tissue point of my central incisor, that means that the height of this, which is 1.5 millimeters, to keep that one intact, my implant should be 1.5 times 1.5. It should be almost around 2 millimeters more to the palatal side. to ensure enough thickness of the soft tissue to have the correct soft tissue height. And that means that our implant should be connected around somewhere there. So by placing an implant and by placing also a abutment which has a S-line, the S-line abutment has been made for this reason. So we have more thickness, vertical thickness of our soft tissue that can keep our papilla intact. But nowadays, from a recent publication of David Varanato in 2019, we know that implants with a platform switch, we can even use less than 1.5, is around 1.2. That means with bone level implants, for example, the Megagen AnyRidge implant, we need around at least 2 millimeters soft tissue to ensure the vertical soft tissue height of our patient. And then we can make a crown and etc. So that means that's the reason why my case failed, because my implant was far to the buccal, which was not planned correctly. So what do we want with the soft tissue in the aesthetic zone? We want to mimic the missing tooth, and we want the same soft tissue as the gingiva, as the prior tooth. And we can achieve that by also placing the implant in the correct position, doing the bone graft, and working on the cervical and the emergence profile of temporary crown. So this is the cervical profile. You need to try to get the same kind of emergence cervical profile of a natural tooth to get to natural aesthetics. And of course, if we're losing the papillas, etc., it's very difficult to achieve this kind of result. But this you cannot do with soft tissue grafting, etc. This you can only do with pink porcelain. So there's also something to keep in mind, that in certain cases, which is not possible to do what we want, we need some pink porcelain to redo everything. All right, so now you've got the theory in your head. Can you recapitulate with me? First, we have time points. We need to try to place our implant immediately, if possible, so we can preserve as much as we can. If we're placing an implant, we need to do some bone grafting as well, because we know that we will lose around 20%. We know that our implant should be placed more to the palatal and have at least 2.5 millimeters of soft tissue thickness to ensure the cervical height. And so let us look at this first case. This is my patient. She has a high smile line, and everybody sees immediately the 2-1 is failing. The 2-1 has a problem, has a large discoloration of the soft tissue, which is of course by the root of the patient. So this tooth has to go. She has a high smile line. She has a very thin biotype. So everything is very difficult in this patient. So my patient has an amoxicillin allergy and a non-steroid anti-inflammatory drugs allergy, and so that's why I prescribed her pre-medication, clindamycin, 600 milligrams 1 hour before, paracetamol, codeine as a painkiller, and a rinse of Blue M. So basically there were no other problems in his mouth. So let us look at this X-ray. 2 X-rays from 2 sides taken by me. Is this enough to place an implant? Is this information enough to know in which direction you need to drill? I believe not. Because what are we missing? We don't know what the width from the buccal to the palatal is. We don't know where the nasopalatine foramen is. So you might end up in drilling of the foramen. So keep this picture in mind and then look at this picture. This is an old CBCT scan of my patient. You can clearly see the roots, the bone. We can see the cross-sectional images, the width, which we can see here. We can see the nasopalatine canal around here. So this gives us a lot of information. Secondly, we need to plan our implant virtually. We need to plan a virtual implant to see in which direction we are drilling. So in this case, we have a 4.0 by 13 implant. And as you can see, I can just keep it inside of the bone. At the most apical part, there's no issue. Remember the literature. The resorption only happens in the most coronal part. In the most apical part, we do not get that much resorption yet. So my implant in this part is quite safe. This is the part which I really should work on. So this is an older case. Next week, we will look at digital implantology, CBCT planning, STL guided surgery, much more easier. But this is a much older case, which I did free-handed. But the idea is quite the same. We need a correct planning. So I need a tooth which will guide me a little bit in which direction I'm drilling. And after that, I can still do immediate loading with this index tooth. So the first step is to try to get a most atraumatical extraction as we can. So by cutting first the soft tissue, removing the tooth very slowly, leaving the buccal bone intact, and then we fit our temporary tooth to see in which direction we need to drill. Then this is our extraction socket. And please bear with me, look at this picture. Imagine you're the doctor, you're the implant surgeon, you just removed the tooth, your assistant is sitting next to you with a suctioning device. You take your first drill. Where do we drill in this extraction alveole? Where do we put our implant? Do you still remember? CBCT, that's where we're going for. So if you look at the left picture, you can see that if I'm drilling exactly in the middle, well, where will I end up? By drilling in this direction, I will come through the buccal bone with my implant. The first drill, to getting my implant in this position, the first drill should be up around 1/3 of the apical at the palatal wall. So at 1/3 depth of my the apical wall, there should be my first drill. That means your first drill should be placed much more to the palatal side. So this is basically what we're doing. We're taking a very sharp drill. If you don't have a lens drill because of your implant system doesn't have it, just find a implant seller who sells you a very sharp lens drill. It's like a spear, you know? And then we go up this palatal part, first in this direction, and then we go up. But that's what we basically do. And from the second to all the drills, we drill in a direction which is every time the same. So these are the golden Megagen drills. So now I drilled up to 30 millimeters, and look at my direction and look at where I'm drilling. You know, I'm trying to get my implant as far to the palatal as possible, as we already planned on our X-ray. And this is what we exactly want. We want our old buccal root, but our implant is placed much more palatal, in the palatal direction. And you can then imagine, if I'm placing my implant in this palatal hole, I can get a very high initial stability and do immediate loading. And secondly, of course, the type of implant is very important. You need an implant which is made for immediate loading if you want to do immediate loading. You cannot do this with a straight implant. You cannot do this with Astra microthread implants. You cannot do that with an Ankylos implant. You cannot do this with a Straumann SP implant or a Straumann bone level implant. You need sharp threads which is made for immediate loading. So this has now a high initial stability. In this most apical part is fully fixed with an ISQ measurement of 76. And what an ISQ measurement basically does is there's a resonance of the implant with the bone, which will be measured. And if the resonance is high, you will get, it's very stiff, you will get a very high ISQ reading. And above 70, it's around mostly safe to do immediate loading. Okay, now we know we placed the implant in the correct position. But remember, if I place my implant and do a bone graft, I still get 20% of resorption, right? I still get 20% resorption. So what I also do is suture in a connective tissue graft, which is harvested from the tuberosity, place a membrane, do a bone graft, and then we can make a temporary crown. So this is the old-fashioned way. This is the old-fashioned way. Next week, I will show what we currently do in our office, but this is the old-fashioned way. So we take a temporary cylinder abutment, we cut it, we make with composite a temporary tooth. Now a temporary tooth has been made, we polish it, and we try to ensure that there's enough thickness for the soft tissue again, so we have the correct soft tissue depth. And this is now our implant, and before placing our temporary crown, I always use some oxygen from the company of Blue M. By inserting the Blue M gel inside of the implant, you will get less inflammation around your implant. And basically we will get from this situation, before surgery in 2 weeks time, the patient comes into our office with much more soft tissue, with a very healthy situation, and the patient can function immediately with a temporary tooth. And that we have too much soft tissue, that's not a problem. You can rather have too much soft tissue, because this tooth needs to stay in our patients for around 15-20 years. And in 3 months healing, you can see the soft tissue is retracting a little bit. This is the bone level. And after removing a temporary crown, this is already our emergence profile. So now here we have enough soft tissue. We've created some papillas, and the cervical height is okay. And remember, this is an old-fashioned case. We use a fully titanium abutment, fused porcelain on top. But if you have enough soft tissue thickness, do you see anything around this soft tissue? If I told you this was a fully zirconia implant, fully zirconia abutment, and a porcelain crown, you would have believed it as well. This is the most important thing. We can use titanium implants, we can use titanium abutments even, but only if we ensure the biology, placing the implants in the correct position. And then this is what we can achieve for our patient. In 1 year time, we have the correct soft tissue, we have the correct emergence profile, which you can only see from the sides, of course. So try not to focus too much just on the front picture, because you also need to look from the side. And this is now 1 year post crown placement, and this time point the patient has the tooth for 5 years and the soft tissue is still the same. So this is quite a successful case. So this is the understanding of placing an implant immediately, and next week we will go in much more detail of placing those implants immediately. If you cannot place your implant immediately because there's some kind of soft tissue defect, you can do immediate delayed implant placement. And what we do with immediate delayed implant placement is that we have the bone and we can place an implant, but there's some kind of soft tissue defect. And by trying to rebuild the bone, we still have a problem around here. So in the past days, I would go for removing the tooth, placing the implant, and doing a large bone graft. And this is also, of course, possible if you have large defects. So this is our patient. The central incisors are already removed by me, but you can see there is a clear inflammation. So the biggest advantage of placing your implants early is that the bone has not fully resorbed yet. So although there is a huge bone defect in the most apical part, I can still place my implants. So we drilled inside of the socket, we planned correctly, and the implants are pushed against that palatal wall. You want to have those implants as far to the palate as possible, because that palatal bone is very hard, that will not resorb, and placing, of course, in the correct depth, around 4 millimeters of the zenith of the soft tissue. There's a huge bone difference, so this part is very easy. Here we have the bone peak. At the 2-1 there's a 2-wall bone defect, so that means this is more difficult to graft. So we grafted everything. We placed an ePTFE membrane. We gave it some PRF membranes. We put over it the PTFE suturing and some oral gel wound support. So, although everything went well, in 2 weeks, in 4 weeks, the soft tissue just started to open up. And unfortunately, we got a large dehiscence after 8 weeks. And this is a problem, of course. This is a known problem for these PTFE membranes that once they open up, you get a massive problem and the soft tissue will not close anymore. So it will open up, open up, open up, open up again. And some colleagues just say, well, let it heal because below your opening of your PTFE membrane, you will get new epithelium and then you can just use that bone. So in my belief, that's not the best way. Just remove your PTFE membrane because it's a non-resorbable membrane. The soft tissue cannot close. Place a resorbable membrane, place your PRF membranes and try to suture as best as you can. And the good thing of this is that in 6 weeks time, the soft tissue will heal quite well. And in 3 months, we did a second stage surgery where we made a apical repositioned flap. And with an apical repositioned flap, I just mean that if we have this much bone and we do our bone augmentation, to close the soft tissue, we must make a cut inside the periosteum and then move up the soft tissue. So the soft tissue gingival complex of the keratinized soft tissue and the mucosa has been pulled up. That means at second stage surgery, we need to pull it back again. So even though of our complication, the bone has fully healed, this is now a mineralized bone. And then we scratch away some bone until we get to the implants, and then we make some temporary crowns. And remember, the keratinized tissue has been moved back. And this is one of the key factors in implant dentistry, keratinized soft tissue. So even though this looks very bad, the most important thing is I have keratinized soft tissue. In 3 months' time, this keratinized soft tissue will heal as a very hard and stiff soft tissue. So in this case, my patient had now enough hard and soft tissue. And eventually we made 2 Emax crowns, which were cemented. And if you see where we're coming from, I think the most important thing you see is that we took all those key factors into mind again. So we placed our implant in the correct position. We ensured there's more than 1.5 millimeters of bone around the implant, as you saw. We ensured there's enough keratinized tissue around our temporary crowns. We played with the emergence profile, and this is then eventually what we have. And remember that this part here, this part was lacking the most. Here we were really lacking the keratinized, the papillae. Here was a large bone defect, and which has been corrected now. And in 3 years post-op, you see everything is still in a good situation. And even the soft tissue is now coming down a little bit, and we have a healthy situation. Around the bone everything is okay. And this is where we basically came from and ended up. Just by doing the biology is very important. So we took the liberty of showing you cases what we can do if you remove a tooth and place an implant immediately, which is, I think, the best way to go. If you have the possibility, place your implant immediately, but try to choose an implant which is suitable for immediate implant placement and immediate loading. So try to avoid tissue level implants, try to avoid straight implants, try to avoid implants with micro threads, etc. You really need sharp threads to place your implants. Secondly, I showed a case where we did a immediate delayed implant placement at around 6 weeks. And thirdly, I want to show you what we can do if we have the width buccal-palatal. So we have the width buccal-palatal, but you cannot achieve any initial stability. Then we need to go for a delayed approach. So again, let us take 5 seconds to look at this X-ray. As you can see, it's a narrow root. And the patient asked me, can you place an implant immediately? And I told the patient, not until I see your CBCT. Always make a CBCT. And if you compare that X-ray with this CBCT, is it still possible to place an implant? No. There's a huge inflammation apical of the root. There's around 2 millimeters of bone below the nose, and that's where I can get my implant, of course. And I can try to place an implant in this way, and we can call it hope for air integration, as my good friend Scott Gans always said, but that will not be possible. So the alternative is just removing the tooth, doing the bone graft, and placing your implants at a later time point. So if we look at this case again, 2-1, we saw there's a massive inflammation. Also in this CBCT, a massive inflammation. So we remove the tooth and there's a huge granulation tissue. And just a very side note, if you have a fistula coming out of the buccal bone, what does it mean? Well, it means that if you open up, there's always a granulation tissue in the periosteum. You cannot clean the periosteum without raising a flap. You always need to raise a flap if the inflammation went through the buccal bone, well, into the periosteum, and cut away all the inflammation. So that's what we did here. We opened up, we scratched away all the bone, and now we're doing the bone graft, because first I want to fill up the bone and place my implant at a later time point. So here we filled everything up with some PRF. So we took some blood from the patient, we mixed the bone particles with the PRF, we placed a membrane, PRF membrane, and we sutured everything, and the patient got a partial denture, and in 3 months time this is our soft tissue. So now you say, well, you still got the resorption, Dr. Abbas. Of course, in the most coronal part, because there's no tooth anymore, which keeps the soft tissue open, so the soft tissue will collapse. But the most important part is the bone. So if I make a flap, I still have the bone, I have the buccal bone. I place my implant, I still have the buccal bone. And of course, I do immediate loading. Again, this is the old technique. Nowadays, we go with temporary crowns. And even though this patient does not have a good oral hygiene, we end up with a crown again with made of the polished zirconia, which has some porcelain fused on top with now a titanium base. And we placed the tooth inside, and the patient did not clean very well, but still the implant is in a good position and we are happy with the result. And the patient can smile again. And he keeps on smiling. And sometimes we even get more lucky, because if we look again at this case, what we saw earlier is where we wanted to do the bone graft. So we remove the tooth, did the bone graft, and sometimes we don't get any resorption at all. The soft tissue stays fully intact. And of course, this is a thick biotype, so this makes things more easy. We made a very small incision. We placed our implant, again, a very sharp implant, which you can load immediately. We took a temporary cylinder, we cut it off. With composite, we made a temporary crown. And after the soft tissue healing, you can already see that the papilla is now slowly moving back already. So again, if we look at these cases, what should we do when? Is always to do placing our implants, going for immediate. I think that's the most important thing to do. Secondly, we remove a tooth and go for immediate delay. And thirdly, if we do not have the possibility for placing our implants immediately, but you have the width, then it's better just to remove a tooth, place our implant, remove the tooth, do a bone graft, of course, and doing a delayed approach where we're placing the implant 3 months afterwards, place the implant directly, and do immediate loading. And why immediate loading is, with immediate loading, we can open up the soft tissue, we can make the emergence profile and the soft tissue profile and the cervical profile, which can lead to most optimal aesthetic results. So When to do a soft tissue augmentation in the aesthetic zone? When we should choose for a situation that we're placing the implant and doing a soft tissue augmentation, of course. Well, the first of all, we need to do a soft tissue augmentation whenever uh, we know we're lacking the soft tissue. So by removing a tooth and doing a bone graft, the soft tissue will always go back. So I think most of the time with immediate implant placement, I try to do some kind of soft tissue augmentation, a small one. You need a really thick one once you do an immediate implant placement in a case where there is already a vertical recession, because then you need to place the soft tissue more cervically as well. So this is our patient. The 1-3 is quite white, as you can see. There's some recession, there's discoloration of the root, and there's a fistula. So here we have a problem. Well, the good thing, this is not a real inflammation. This is caused by external cervical resorption that caused eventually a fistula. But this is not a inflammation of the root or inflammation of the bone. This is because of the cervical resorption. And what did we do? Of course, if possible, you must really remember this. If possible, I will always place an implant immediately. So I placed the implant. The bone buccally was lacking, so I placed the membrane. I did some bone graft between the membrane and the implant. And then from the palatal side, we took a big bunch of connective tissue. And this is a big bunch of connective tissue, so we can suture this inside. And by making a big bunch of connective tissue, we can really expand the soft tissue. And what we do is we place the soft tissue inside of the connective tissue inside of the soft tissue. So you go with your suture from the buccal part in, you come out, you take the graft on one part, and then you go back in the graft. So you have a sling inside of the connective tissue graft. And with the needle, you go back in and come out from inside, outside, and then we suture. And by doing this, the implant, the connective tissue is now fixed on one hand side. And then, of course, we do the same thing from the other side. So we go in here, grab this soft tissue, take it again, going back in and suturing again. So then we achieve this. So now the whole soft tissue has been moved inside out, right? So once it's inside, at this part, you still have the soft tissue outside outside. That could cause a necrosis of your soft tissue which is on the outside. So I try to grab here a soft tissue again, going back, going buccopalatal, coming back buccopalatal, getting in, and then making another suture. And this will help me to pull the soft tissue more to the cervical height of my implant. And now in this case, after 2 weeks, you see a very nice healing of the soft tissue. Is very much more thickened. So here we have the thick soft tissue which has been created, and by comparison on beforehand, and that's why we make pictures, of course, we try to compare, is by comparison the soft tissue is now coming down, and in 3 months time we get a very nice healing. So this is now very natural, very thick. And remember, this is still a composite. This is a composite restoration, after which we can replace the composite restoration with a ceramic restoration with a zirconia crown. And we have this situation. But the downhill, the negative side of doing these connective tissues is, of course, we can get complications around these cases. We can get sometimes partial necrosis or full necrosis. And that's the downside, of course, because if you look at this patient, again, a fracture of the 1-1 because of a deep bite. You can see also some wear of the incisal edge of the 2-1, but there's around 3 millimeters of soft tissue defect. So we took the tooth, we removed the tooth, and this is what we'll discuss next week more in detail, making a CBCT planning and making a guide. So we remove the tooth, and this is now our alveolar. And we want to place my implant immediately, and we made a guide before and sign. So this is now a guided implant placement. So we go with the drills through the guide, and also the dental implant goes through the guide inside in. So this is now our tooth in the correct position. So what was the correct position? More to the palatal, depth of the implant, 4 millimeters of the soft tissue depth, doing the bone graft implant placement, and we did a connective tissue graft. But as you can see, this connective tissue graft isn't as thick as I showed you before. This is a little bit too narrow. There's too much fatty tissue, so this harvesting of the connective tissue did not went very well. Even though I tried my best to suture everything in, because it's just a small part, we get a partial necrosis. So what's the difference between a partial and fully necrosis? Is the partial necrosis a partial necrosis means that there's it's not fully necrotic, but just part. And what you need to do is just remove that part, just cut the necrotic part outside, and in 2 weeks time the healing went well, and we went from this situation to here, in a situation where the soft tissue is now fully restored again, and we can make a nice crown for our patients. But also sometimes we can get a full necrosis, which can cause a big problem for us. So here we did a connective tissue graft. As you can see, we get a large retraction of the soft tissue. And again, the connective tissue was too thin. So you need a big piece of connective tissue to suture everything in. And by doing so, we can ensure a correct situation of our implant placement. Okay, well, that's almost it for today. And next week, we will continue, of course, on the CBCT planning and placing our implants guided in the aesthetic zone, where we can achieve much more predictable and easy results. But concludingly, it's very important, first of all, to know the design of your implants if you're placing implants in the aesthetic zone. Try to avoid wide implants. Do not place wide implants in the aesthetic zone, because we want to have enough soft tissue and bone. We want enough bone around surrounding our implant. The body will not give more bone than it initially was, so you need to stay inside of the bony envelope. If you place a 5 millimeter implant and the width of the buccal-palatal direction is only 6, you're lacking the bone, is impossible to augment as well. So try to stay at 3.5 to 4.0 millimeter diameter. Secondly, you need an internal connection with a tapered implants with sharp threads. So the threads should be very sharp to get a high initial stability, which will really cut inside the bone and will be very fixed. Don't try implants which are straight, which do not have sharp threads. Do not try it with tissue level implants, because these implants will only give you failures. So choose the correct design of your implant. Secondly, the planning. You need to plan the implant on the correct position. So today we saw is 3 millimeters from the zenith to the most apical part of your 3 millimeters from this, 3 to 4 millimeters from your soft tissue depth, 2 millimeters minimal to the palatal part to have enough thickness of your soft tissue. So the planning where we're placing is very important. And the location is the same thing, of course. So you need to plan where's your tooth, and then plan your location of the implant. Looking at the timing point of view, the timing is very important. If possible, we go for immediate implant placement, of course. That will give you the best results if you have the correct implant. You need a sharp implant with sharp threads. Secondly, if you cannot place your implant directly and you want to do a bone graft, it's a good idea to do it immediately late. That means at 6 weeks, the soft tissue have healed, so you can make an incision and suture everything again, but the bone is not fully resorbed yet. And the third part is the healed ridge, of course. So if you have a situation where the ridge is healed, you need to augment, or you can just remove the tooth. And if you have enough width, but there's a large bone defect, it's a better idea to remove the way bone graft and placing your implant at a later time point. Then the temporary crown is always necessary because one of the most key factors of placing implants in the aesthetic zone is by opening up the soft tissue with to create perfect emergence profile, as well as a cervical profile, which will give you the best option for the prostate for your patient. So the timing of implantology in the aesthetic zone, immediate implant placement is the best way to go. Immediate delayed, we can do 6 to 8 weeks after extraction, where the soft tissue are still okay. And the healed ridge, of course, after 3 months delayed, or 3 months after extraction. But as you can see, there's a lot of bone resorption already here, so you need a lot of grafting to do. And the last part is, of course, the socket preservation. You can do guided bone regeneration by doing the grafting of the socket, so you can try to preserve as much from the socket as possible. And this is a good idea when you're not able to place your implants, you have soft tissue defects, vertical root fractures, large bone defects, or even pneumatized maxillary sinuses. So this is our socket preservation, and it's very important to know the timing of implantology and when and how. So with that, I want to really thank you for your attention. Thank you for the OHI group for inviting me to do this lecture. If you have any questions afterwards, you can just send me an email. And I hope sincerely you will all come back next week, where we're really going to look at the CBCT to see when we should place our implants, in which way, etc. So send me an email if you have any questions, and I hope to see you next week, 8:30 Amsterdam time, so we can go into the CBCT and the guided surgery. I thank you for your attention. Stay safe, and bye now for now. Bye.